Good day, everyone, and a very warm welcome to the Philips 5th International COVID-19 Learning Webinar session. Certainly, we are living in interesting times, to say the least. We've had to adapt very quickly to the evolving situation, and at Philips, we have mobilised our global resources to fulfil our triple duty of care, which is continuing to fulfil customer critical needs, ensuring the health and safety of our employees, and ensuring business continuity. 3 days after the World Health Organization announced the COVID-19 outbreak as a pandemic, we organised our first international learning on COVID-19. We invited frontline experts from Wuhan, China and Italy to share their frontline experience on disease management, mechanical ventilation and life support for COVID-19 patients. The reason we did this at the time was that COVID-19 was a novel disease and we were all tackling it with minimal data and without standardised procedures. Therefore, it was important that the healthcare community came together. It is still important that we come together so we can share our knowledge and experiences to learn and find solutions together. The first webinar was very well received by the clinical community. We saw a continued need for exchange of information, and by following the COVID-19 epicentres, we organised the second, third and fourth COVID-19 webinars. This saw a total of 28 international speakers and panellists from 13 countries share their valuable knowledge and best practices to support healthcare providers in the fight against COVID. COVID-19 is accelerating the transformation of healthcare. In tandem with this transformation, we have a comprehensive portfolio of products, services and solutions that address the preparedness, response and recovery needs relating to COVID-19. We were also privileged to collaborate with Temasek Foundation, a Singapore-based philanthropic arm of Temasek Holdings. Temasek Foundation supports a diverse range of programs that positively impacts lives and communities in Singapore and beyond. The collaboration between Philips and Temasek has been instrumental in the COVID-19 response towards supporting health systems, hospitals and healthcare professionals in caring for their patients. Wu Ji from Temasek Foundation, who is the COVID-19 task force leader, will be sharing more details on the Foundation's COVID-19 response towards management, future planning and prevention. I would also like to acknowledge Temasek Foundation for its leadership, generosity and foresight during this crisis. I would also like to take this opportunity to extend a special thank you to Dr. Elliott, Professor Stefano Nava and Professor Nicholas Hart for joining us in today's session to share their COVID-19 reflections during the last 9 months and their most recent experiences in the second wave in Italy and the UK. We hope that today's session is useful and provides new insights in the fight against COVID-19. Thank you so very much.
Thank you, Angela. At Temasek, we believe that corporates, together with government and community, must all do our collective parts to fight and defeat this pandemic. This is a time to do right and do good for the community. And only when the community is thriving can we do well as an investor. So together with our partners, we have spearheaded various initiatives to safeguard our community, galvanize our ecosystem partners, and enable individuals to contribute in their own way during this long battle against COVID-19. We have focused across 5 different areas: diagnostics, containment and contact tracing, treatment, protection and prevention, and lastly, enablement. Locally, there were many initiatives. Temasek Foundation, for example, we partnered with one of our investee companies, Advanced MedTech, to manufacturing a critical care ventilator in Singapore. Advanced MedTech has received emergency use approval from HSA for its ventilator, which allowed for an innovative remote management and monitoring. This feature is especially relevant for pandemic and infectious diseases. A $10 million manufacturing facility has been fully set up in Tuas, and the workers have all been fully trained for production. So when the production is fully ramped up, 200 ventilators can be produced monthly, with the ability to ramp up further and scale up depending on market needs. Besides taking care of our local community, we also recognize the needs to ensure that communities beyond Singapore are well equipped for this pandemic. Virus does not respect borders. So where we can provide help across borders, we have done so. Through Temasek Foundation, we contributed PPE, ventilator, diagnostic kits to healthcare partners in the region and even further afield. To date, Temasek Foundation has enabled some 40 countries to better deal with the virus. By providing test kits for over 550,000 tests, over 20,000 first-line and last-line oxygen and ventilation equipment, and more than 3 million surgical N95, KN95 masks, and more than 9 million reusable masks to various groups in the international community. In this effort, we have worked with many partners, including Philips. Together with our many partners, Temasek and Temasek Foundation will continue to step forward, do right, do good for our community, as we believe that only with a thriving community can we do well in a post-COVID-19 world. Thank you.
Welcome to what will hopefully be the final webinar in the series on COVID-19. We've had a number of these over the last few months, which have been extremely important in helping to guide clinical practice, because earlier in the year, we were hit by a tsunami that appeared to come from almost nowhere by a new disease in huge numbers. And we were very fortunate to be able to get some useful insights, first from China and then from Italy, which was particularly badly hit in the first wave. We learnt about new ways of delivering the service, both in terms of the way that ventilatory support was applied, but also we saw the rapid construction of intensive care units, novel strategies such as moving patients around the country in high-speed trains, the use of remote monitoring to allow patients to be managed outside a traditional intensive care setting. We've had a particular focus on non-invasive ventilatory support, initially mostly about the use of CPAP being provided with a helmet interface, but subsequently we focused more on high-flow nasal therapy. And we thought it would be useful just to take stock of where we are and to go back to a couple of the contributors to the earlier webinars and to see what they had learned and what they would be doing differently now. And we're very grateful to Professor Stefano Nava from Bologna in Italy and Professor Nick Hart from London in the UK, giving up their time to share their thoughts with us. Hi, Stefano, nice to see you again. Earlier in the year, we spoke a few times on similar sorts of calls about COVID-19 and really wanted to take the opportunity of just catching up with you and finding out what you've learned, what you're doing differently now, what you will do differently going forward.
Hi, Mark. This is a quite difficult question. I think we learned a lot. The first thing I have to say is that at the early beginning of the first wave, we were probably too aggressive with our patient, considering that most of the patients were intubated. Now we are much more conservative. I make some example. All the patients during the first wave with a PF below 150 were considered eligible for intubation almost right away. In this second wave, we have plenty of these patients in our unit that is dedicated this time only to non-invasive technique. During the first wave in our unit that is divided in two, one is the respiratory intensive care unit and the other one is a sort of respiratory ward unit. We were mostly intubate patient in the respiratory intensive care and we use non-invasive support in the other patient. Now all the units is dedicated to non-invasive technique. And as I said, we have plenty of patients with a PF lower than 150, and I would say around 15–20% of the patient with a PF lower than 100. So this is probably the lesson that we learned during the first wave. Don't be so aggressive at the beginning. Most of these patients, they are going to recover even with non-invasive support.
How long are you keeping them on NIV for?
For our paper published last week on the ERJ, we use 3 different devices: NIV, high-flow nasal cannula, and CPAP. Usually, the sicker patients are undergoing an NIV trial. And then I would say, the moderate respiratory failure patients are supported by high-flow nasal cannula. Well, CPAP is just in between, I think. This is real-life stuff. I mean, we don't have protocols, to be honest. Why we don't have protocols? For a simple reason. We learned during the first wave that you need to adapt yourself to availability of a specific support, and then always to keep in mind that you do not have to consume too much oxygen. Because during the first wave, especially up north in Lombardia, they apply a lot of high flow and CPAP, and they run out of oxygen in the hospital. So you need to balance. Don't ask me, Mark, which guideline do you follow? We don't follow guidelines, because during this, we learned that, as I said, probably sicker patient, NIV, moderate patient, high flow. Among them, the less tolerate CPAP device, especially with the helmet, as what we use, is probably among the three devices the less tolerated.
Okay. And roughly how long on average would people be on whichever of those three modalities? How many days on average? And then how much of time each day? Because I remember in one of the talks from China, there was the suggestion that people should be on it absolutely all the time without any breaks at all.
No, I mean, for how long depends, obviously, at this stage the patient is. Some patients, they come to the hospital directly and they are pretty sick. Others, they are admitted to the hospital and they're not as sick as the previous one. So it depends. On average, we keep the patient on non-invasive devices between 4 and 6 days, usually, roughly.
Yeah.
How long? Well, this is even more complicated because, as you know, here at least we use a lot of pronation. We also prone the patient. So it's a sort of mixture. Some patients, they tolerate very well being on NIV or high flow and be pronated, some others not. So it's a sort of, I would say, balance between the hours on NIV and pronation, usually. To be very clear, for NIV, we use the rule of thumb, 3 hours in, 2 hours off. And usually during the 2 hours off, we prone the patient. When we use high flow nasal cannula, we use a lot of pronation during high flow nasal cannula because probably it's easier for the patient to tolerate prongs rather than usually we use a full face mask, so it's more complicated. I would say it's around between 10 hours a day, more or less, plus eventually pronation. And then we bring this patient usually quite easily to oxygen, standard oxygen. Unfortunately, right now, we cannot use the combination of NIV plus high flow just because we have limited numbers of devices. So this is the main problem.
I completely agree with you. It's always going to be about a number of complex factors, including just the availability of the kit, the number of other patients on oxygen, et cetera, et cetera. What about humidification? In the very early days, there were concerns about humidification, which I think pretty quickly went away. Is that your view too?
Yeah, I mean, during the first wave, a lot of emphasis was placed on the problem of secretion and sticky secretion, I would say. I mean, I receive a lot of mails from UK, for example, asking me how do you deal with that, but it was never a problem even during the first wave. So yes, obviously with high flow, we humidify the system. With NIV, we humidify also the system. Obviously, if the patient is ventilated more than 10 hours, I would say, a day. Otherwise, we use the classical HME, and obviously we change. While for CPAP with the helmet, no humidification is provided. It's very complicated. It's a mess to humidify this patient with the helmet.
So, just so I'm clear about this, you said that the helmet was less well tolerated than the other interfaces?
Yes.
Yeah. Why do you think that is? Because previously in Italy, you've been great advocates of the comfort of the helmet as a means of providing total ventilatory support. Maybe it's because you're not giving it all the time?
To be honest, when we talk about helmet, we are talking about CPAP with the helmet. With NIV, we use the classic classical interfaces. Well, don't ask me. You should ask the patient why it's less tolerate. My gut feeling seems maybe a little bit stupid and naive, but there was a lot of emphasis even on the media about the use of helmet. And when they interview these people, they always say, wow, this helmet was terrible. You are hooked in a cage and you cannot even remove this. So probably was a sort of psychological thing. Second, usually with the helmet, you tend to keep it more than any other form of interface, because the helmets, it's not easy to remove and put it back, especially for the nurses, because it is clear that with the helmet you reduce the droplets around you, but you need to be very careful when you remove it, because then it is a reservoir of viruses. So the nurses tend to convince the patient to stay more on the helmet, and then they complain a lot. It's not evidence-based, but it's a real-life experience, I think.
It's interesting, and I think certainly in the UK, the pictures of rows of people in northern Italy on helmets had quite a big impact on the general public. And of course, as you know from previously, they were not used much here because you were using them all in Italy and we couldn't get our hands on them. So I guess that's reassuring that not having the helmet is not a major disadvantage. So just to summarize, that for the sickest patients being ventilated non-invasively, you'd go for bi-level ventilation. That high flow is the least sick in terms of oxygenation, and certainly looking at the data that you presented, that would be borne out by that. They had higher PF ratios, lower SOFA scores, etc., with CPAP being somewhere in between, with a lot of use of proning when either on high flow or when the patient is off their ventilatory support. And with regard to interfaces, using the classical interfaces rather than the helmet.
Absolutely.
In terms of when to stop, there are two reasons for stopping. One is the patient is getting worse, in which case they need intubating. The other is that the patient is getting better. So perhaps, first of all, dealing with the patient getting better, how do you wean the patient off their non-invasive ventilatory support?
First of all, when we stopped, I want first to reply about intubation. So far, we treat more than 100 patients here in our unit. I don't know the exact number because we are on the two different floors now. So one floor is for sickest patient, the other one is for less severe. And we intubate so far 3 patients. So it's a very, very low rate of intubation. In this patient, I mean, it's clear that our general ICU is full of intubated patients. I mean, in patient initially treated with non-invasive support. So very few of them. How do we win the patient who are doing well? Well, in a very simple way. For NIV, we use the classical rule. Rather than reducing the level of pressure, we reduce the number of hours a day. But usually, I mean, for CPAP, it's the other way around. Like, we start to remove abruptly the helmet and see how the patient is going on when they reach, during spontaneous breathing, let's say a threshold of around 200 or something. With high flow, it's much simple because you can reduce the FiO2 gradually as for oxygen, and then it's a natural pathway to be weaned. What else I would say about weaning? I would say that we learned that in this second wave, contrary-wise to the first, there is a sort of breaking point in which the patient mysteriously, sometimes I say, they start to improve dramatically, even if you don't do much, unless methylprednisolone or dexamethasone. We don't use only dexamethasone, we also use methylprednisolone for several reasons. I don't know if it's the effect of steroids, but after 4-6 days, when they go well, they abruptly change. Weaning is easy, I think. Okay. It's not like in COPD patient and we were used to. It's very empirical. One day, they change.
As you know, I'm a great sort of fan of distinguishing failure of non-invasive versus failure of ventilation, and that the way that they respond subsequently to intubation. And again, I wonder what your experience of that has been in COVID, or whether just with so few patients intubated, it's really hard to say. So what I'm getting at here is, if you've tolerated non-invasive interface and the problem is not being able to ventilate them, how do these patients do when they're intubated, or are the numbers so small that you can't really comment on that?
No, I mean, all the 3 patients that we need to intubate are doing fine. All of the 3 patients, they were really tolerating very bad.
So it's a failure of the non-invasive bit rather than...
I tell you one story. I mean, it looks funny, but it's true. One guy ate so much the helmet that one night, I was not on duty, but my colleague told me, he woke up, he removed everything, and he was walking in the corridor with the helmet stick on his face because he could not stand it at all. So this guy, we need to intubate it, and he's doing fine now because he can also be pronated. So
okay, and then lastly, what about PPE? Any changes in your practice with regard to that, infection control?
All my colleagues, all the nurses are much better than I am in dressing up, in placing PPE. We test more or less all our staff every week, and so far, zero of them got tested positive. Keep our finger crossed, but after more than 4 weeks, everyone is still negative. During the first wave, let's say in our unit, 6% of the people tested positive. That does not necessarily mean that they got sick, but all the others did fine, and this time we are doing even better. Okay. So I think it's easier for the staff here to be contaminated by their kids rather than here, because they know how to act now.
Yeah, I mean, I think that's absolutely right. I've looked at this quite a lot in the last few weeks, and I think that actually a lot of the focus has been on the infection risk of high flow, of CPAP, et cetera, whereas actually the patient who's not needing oxygen but who's sitting outside coughing is a much bigger threat to those around and to staff. In the high dependency unit, in the intensive care unit, the infection control procedures are much better. People are wearing PPE, but I think actually the procedures are probably less aerosol and droplet generating in a way that matters than we first thought.
And then if I go even deeper, and I say that during the first wave, most of the people that got infected got the infection during the first couple of weeks of pandemics. Yeah. And think about it. Out of 200 Italian doctors who died, 50% were GPs, general practitioner. And if you think, you don't go to the general practitioner using NIV of high flow. Yeah. So this means that you are totally right, as usual, that it's more dangerous when someone coughs in the bus or in the subway rather than going with the right protective equipment in the unit where you treat patients with COVID.
Stefano, as the first time around, that's really helpful. I think that at the beginning of all of this, your insights and what you told us all was really, really helpful, because we were all kind of walking in the dark. So it's really good to touch base with you. Have you got one final comment that you would like to leave people looking at the next few months?
From a medical point of view, I really hope that one of the 3 or 4 new vaccines are going to work. I'm not skeptical at all, as most of the people.
I think for me that when the dust settles from all of this, there are lots of lessons that we need to learn. And I guess one of them will be a recalibrating of the way we design and run our hospitals to deal with infectious diseases, because I think that we haven't really had to face this before. We've really been looking after people with chronic diseases, and infection, at least apparently, has not been a huge part of it. But I think, for our COPD patients, it's probably been a lot more than we realize, and that, contact with others leading to viral upper respiratory tract infections, exacerbations, etc. In hospital, nosocomial transmission. It's always staggered me how many of our patients with exacerbations of COPD go on to get pneumonia, and whether it's the steroids, I don't know. But anyway, I think there are lots of issues about the way that we design our hospitals and our medical practice that are going to change. And certainly we discovered that the block that we have for our respiratory wards, for our non-invasive ventilation, has the most terrible natural ventilation. It was so bad that we had to stop doing a lot there because the engineers and infection control people were very concerned about this. So anyway, I think we better stop because otherwise we could go on for hours. Thank you very much, Stefano. That was fantastic. And now it's a pleasure to welcome Professor Nick Hart. Hi, Nick. Nice to see you again. Earlier in the year, we met a few times and discussed various aspects of COVID, and we just thought it'd be a really good idea to touch base again and see what you've learnt in the last few months, what you do differently now, what you are doing differently, what you do differently starting again, and particularly focusing on the ventilation management of these patients, oxygen and ventilation.
Mark, it's nice to see you and really to reflect on where we've been since the beginning of March. And it's been a significant journey for us all, significant journey into what we've learned, the new collaborative and collegiate way we operate, not only within the hospital, but also between different institutions, whether that's nationally or internationally, which I think has been really exceptionally helpful for understanding the disease associated with SARS-CoV-2. When we received our first patient on March the 3rd, earlier this year, I don't think we had any understanding of the disease or any expectation of what the actual volume and the acuity of the patients would look like. As you know, we were exceptionally busy in Southeast London. Southeast London has a population of, surrounding my hospital is 650,000, but it's an extended population which goes up to 1 million when we include one of the other regions. And that's what we did. We set up a collaborative process between the hospitals across Southeast London so we could provide mutual aid and help each other out to provide the highest level of care to patients. And there's no doubt that helped keep the hospital systems running in Southeast London. At that stage, you know, throughout that period, we saw 353 admissions through our ICU. The survival rate within our hospital was 7 out of 10, and 8 out of 10 patients received invasive mechanical ventilation. In fact, those patients that received non-invasive respiratory support, which on the whole was mainly high flow, was actually post-extubation. And so we use very little in the pre-intubation phase. And the reason for that is we had a limited supply of oxygen. We only had 3,000 litres per minute. We peaked at 153 ICU patients on the 13th and the 14th of April, and then subsequently saw a decline. And it's interesting that during this time when obviously we were going through patients who were going through the weaning phase, and we know that patients who received a tracheostomy as part of their treatment, that was about 1 in 3 of our patients that came through. They had a weaning time to decannulation of 35 days. If we imagine these were multi-organ failure patients, one wouldn't imagine that was a long or protracted weaning time. And, you know, we learned there was the simple weaning patients. There was those with renal replacement therapy as well, which were a bit more complex. There were those who acquired an acute brain injury whose tracheostomy was more permanent, or for some of them it was just a delayed decannulation as they recovered during their rehabilitation. And there was these slightly complex folk because of the delirium. We saw a lot of ongoing delirium, partly due to the fact of the disease process itself, but partly due to the fact we were using drugs that for many years we hadn't used, in terms of morphine, midazolam, and all these drugs we used to use in the ICU because the propofol was so short. So there were some parts of this were iatrogenic and some parts were related to the disease. After the first wave, we knew we just had to get prepared. And it's interesting that that preparation for the second wave started pretty much almost immediately, to understand what we were going to do the next time, and not necessarily say what we're going to do in the ICU, because we felt with those countries that were showing a second wave that it would look slightly different. What we meant slightly different was what was going to be the acuity and what was going to be the volumes of patients coming through. And so we've developed the Big Five, and the Big Five for our institution actually rolled across NHS London and beyond. And really what we're focused on for the Big Five is making sure people get appropriate oxygen treatment, making sure people get appropriate hydration. I think on the first wave, we thought this was acute lung injury, ARDS, Our history taught us that we must ensure that these lungs are dry, and that was probably not necessarily helpful with the amount of acute kidney injury we saw. At some stage we were up to 40% of patients who were on a filter in the ICU, which was a very heavy burden on the system. We didn't think about antiretrovirals and IV remdesivir. I think we understand now with IV remdesivir that it may have a place, and obviously that's up for discussion, but it's definitely early on. I don't think there's any point giving this drug once somebody's ended up on a ventilator, and there's no evidence to support that. Using steroids, dexamethasone, I think, has been probably the game changer that we've seen, but also adequate thromboprophylaxis and making sure we're changing our thromboprophylaxis depending on a patient's clinical condition. We're much more aware that these patients can have a thromboembolic event, that we will then ensure we get the appropriate investigation, and then we can adjust their treatment as well. We put that all together as a package, and that package is placed at the front door of the ED. That package has actually been disseminated to our local general practitioners. And not only by doing that, we've actually now developed the admission trigger and discharge system. So when patients we feel hit the criteria of a low, medium or high risk, and they have features consistent of those parts of the condition that we're concerned about, a patient presenting with breathlessness at day 8 is a big worry. A patient presenting with just fever at day 4, who may be young, then what we will do, we'll assess the patient, discharge them, but they get daily telephone calls for up to 10 to 14 days afterwards, because just by talking to somebody on the telephone, you can assess a significant amount about them. Obviously around respiratory, can they talk in full sentences? Are they breathless walking to the bathroom? How long does it take to recover? And we've set this up as a standard now. So a lot of the work has actually been trying to prevent people deteriorating. And I think that's always what we were driven to do, if we can prevent the ICU admission. Unfortunately, even despite all these aspects of care, 1 in 3 of our patients currently have COVID-19 in the ICU. Currently today, 11 patients are on ECMO. Those ECMO patients are external referrals. We've had no internal transfers for ECMO through our own front door, through the emergency department. And I do think, and we'll obviously get more data in due course, but the concern arises the extended use of CPAP and high flow and the patient-induced lung injury. There's a recurring theme of patients being on non-invasive respiratory support for 7 to 10 days and then getting intubated and developing severe acute, or having a acute lung ARDS and then a pneumothorax or something else causing catastrophic change in their clinical condition. And we've seen that through the ECMO. Proning patients, very much more selective about proning patients and those who respond and don't respond. There's a lot of work we've been doing to make sure, again, the processes are in place to ensure we provide the best care to our patients.
That's really helpful, thank you. So just to focus on the whole issue of non-invasive ventilatory support, I think you said 8 out of 10 were being invasively ventilated. Has that changed over time? And who gets non-invasive support in your unit?
There are more folk that receive high flow, but we only do this for a short period of time. And if we don't see a response, generally in 12 to 24 hours, then we would then say this patient's hit a plateau. So then we would intubate the patient. As you know, Mark, plateauing in the HDU is not a great sign. You need to see clinical improvement. The patients coming through the ICU this time are different. So if they are going on to non-invasive respiratory support, we just have to be mindful of that. The patients we've got on the ICU now, the median length of stay is 13 days. Median length of stay last time was 11 days. So you're getting less patients, but patients that, despite not requiring renal replacement therapy, are ventilated longer. I think there's a message there that people are trying to use antivirals, corticosteroids, thromboprophylaxis, hydration, and then non-invasive respiratory support, but it doesn't seem to be what is effective in part. Interestingly, and I think this is a really important point as well, is we've just going through the data we had from the first wave to try and influence what we're thinking in the second wave. So the data from the first wave we've got data, a complete data set on over 1,000 patients that came through. And the reason for doing that, I wanted to understand what the impact of do not resuscitate orders were on outcome. And so we divided the patients into, as you can imagine, groups that were for resuscitation and those who weren't. And the reason I say this is about the use of non-invasive respiratory support, because I think some people felt that we can use this as a ceiling of care, give people non-invasive respiratory support, but we're not going to escalate them to intubation and ventilation and full intensive care treatment. And that seems very reasonable because that's the background we come from. There is no doubt if I said to you about a pneumonia, that's what we would try. And so there's other conditions we've dealt with. The interesting part I raised that, and when you look through the data, you see of those from the published series, and we have to call these published series because there's no actual randomized control trials, but the mortality is 45%. So you say to yourself, okay, 50% of patients who you do not intubate, you give them a CPAP, 50% are going to die. When we looked at the patients on our wards who received intravenous fluids, judicious oxygen therapy, nursing care, we saw exactly the same mortality rate, and these were a sicker cohort of patients. So I think we just got to be mindful of the fact that what we do may not necessarily be effective in the particular patients we choose. And so I honestly believe that some of the patients we will see and we will use high flow, but we will have it used for a limited use. And if we are concerned, especially those folk who have that large tidal volume, that feeling that they have a large tidal volume, which isn't hypoxia driven, there's a centrally mediated process here. So they have a large tidal volume, high pleural pressures on the inflamed lung, causing worsening on the back of the viral pneumonia, worsening, pulmonary edema in essence, and that causes further restriction. And then the respiratory rate rises and the oxygenation requirement goes up and the saturations fall. In fact, the data we did from the cohort that we had, we found that the FiO2 requirement goes up 10 hours before deterioration, and the respiratory rate goes up 5 hours. And again, this is all a reflection of the patient who is failing in terms of their lung injury is progressive. And I think we just got to get smarter. And when we're examining people, and all these folk, if we are doing this, need to be in a critical care environment where there is ability to be able to intubate and look after these. I always go back to the point and say, prior to COVID, if you're a 55-year-old with a viral pneumonia, would I strap someone to a CPAP for 7 to 10 days? Well, we wouldn't do. We would make sure that we assessed, we made sure that we gave them non-invasive respiratory support. And then as time went on, if they weren't making progress, we would intubate them because they get more and more agitated, more and more, delirious and all these other issues that arise. So I think we've got to think about how we would do things, not in an environment where we don't think we've got access, but how we feel that we should manage these patients. Because currently there's no evidence. And obviously the Italian series, but all these series are very difficult to understand for application to your own patients.
I agree completely. I think it's extremely difficult. I mean, it's very interesting. I've spoken with Stefano reflecting, and actually they've gone in a different direction in that it's many more patients on non-invasive and far less intubation. And I think how one is ever going to pick the pieces out of this as to exactly which is the best strategy is extremely difficult. I mean, clearly the best way is to have a randomized controlled trial, but I think that the UK Recovery RS trial sadly is just not recruiting the numbers to give certainly definitive answers, certainly based on the initial power calculations and so on and so forth. And I think somehow when the dust settles from all of this, or during the next hiatus, we need to try and work out ways of actually analysing data, comparing and dealing with the many, many confounders that there are. Do we need a clinical trial? And would it be feasible to give this through a non-invasive system?
There are some reports of non-invasive use, and they're all series of patients, but they seem to have an improvement in the oxygenation. None of the reports I've seen report outcome. So if I talked about proning people who were not, because we had a program where we would prone the patients who we were trying to avoid intubation. And again, 1 in 2 chance that the patient would require an escalation of care. So about 50% of the patients needed intubation and 50% didn't. And it was those who responded. But interestingly enough, when we looked at their oxygenation scores, whether it was SpO2 rocks or whatever, but when during the actual proning, there was an improvement in oxygenation. But as soon as you flip someone back on, or they lay back on their back, that was all lost. So it's really important to understand what we're doing with patients. And we never did any of the proning outside of the HTU environment if some of it we were going to escalate, because we got to a stage of being concerned about a patient enough that we wanted to make sure that they were able to lie on their tummy, lie on their side, lie on their back. And in fact, that shows a cohort of patients, because to be able to do that is quite a tough ask when you're pretty ill. And so, the patients who are frail and whatever, we've seen that in our data on the do not resuscitate data. The patients who do not resuscitate, their frailty score is significantly high as well.
So what about the longer term? You mentioned quite a lot of patients ending up with tracheostomy and so on. Are you ending up with patients needing oxygen when they leave hospital, patients going home with ventilators at home?
So ventilation, as in non-invasive ventilation, was not required. Very, very few. There was a few patients who required to go home with CPAP, and that was the OSA type folk.
Okay, right.
So they went home because we diagnosed them with obstructive sleep apnea, because that's obviously one of the conditions that we would have expected to see in any critical care cohort. So they went home on CPAP to control their upper airways obstruction. As regard the patients for going home on oxygen, the ones who ended up on ECMO, that's what we actually saw more of. There are a number of those patients, and when I say a number, it's a small proportion, required long-term oxygen therapy, and we're following those patients up. For patients who were post-ICU after their COVID infection, they were all put through the post-ICU COVID clinic, so they've been followed up, and that's just not physical, that's psychological, as well as pulling together cognitive as well. For those who came to hospital who avoided the ICU, we had the post-COVID clinic, and that's another interesting area that will come increasingly important, and we can see how increasingly important the whole idea of post-COVID syndrome is. But as clinicians, we need to think about focusing on that aspect as care, as well as the acute aspect of care. And interesting, by looking through the data that's been published for those studies, following patients up in clinics afterwards, you see the main features of the symptoms being fatigue, which I think we all agree with any post-viral type process, but breathlessness, cough, muscle and joint pain, and poor sleep quality. There's a smaller proportion that have anxiety, depression, and PTSD features, but they're obviously a proportion there as well. Interesting from those studies, the only one that looked at cognitive function said the test was not good enough. So I think there's much more work we need to do about cognitive function post the acute illness as well. But I think going back to the process of what you asked me about non-invasive respiratory support pre-ICU admission or pre-critical care admission, we have not used much in the way of any of these. We've used a little bit more high flow, I think it's fair to say, but not excessive amounts of high flow. But we've only done it as a trial. We're really clear it's a trial period prior to intubation. And some of the folk haven't required intubation, but it's not necessarily this as a game changer from our clinical observation. You need a trial, randomized control trial, to actually answer that question.
Okay, so Nick, just clear what we're saying. It's been interesting because, I say, it's quite a different approach to, I think, what Stefano and colleagues in Italy have been taking. But basically, and really I'm just reiterating what you've just said, is that a short trial of non-invasive ventilatory support, which would predominantly be high flow, and that plateauing is not good enough, that the patient's actually got to improve, and you would have a low threshold for intubation. Not a huge fan of proning. If it works, fine. If it doesn't, then you don't pursue that. Again, in Italy, I think they've been rather more aggressively using proning. So non-invasive ventilation, then with periods prone, then back onto the non-invasive ventilatory support. And generally speaking, that the long-term sequelae are probably not much different in terms of patients requiring ventilator support, oxygen, etc., to what you'd expect in a general ICU population. Perhaps some specific features of COVID, but probably difficult to really disentangle what's COVID and what's prolonged intensive care stay. Thank you. That's really helpful. Have I understood what you were saying correctly? Is there anything else you want to add?
The proning for us in those self-ventilating patients is cautious, because we know that we have to be cautious with these folks. What I will say as well, that the low-dose dexamethasone study, which was so important, we just need to know when people start to deteriorate, increasing the steroids if the procalcitonin is low, and we're convinced this is a hyperinflammatory response, or there's ongoing systemic inflammatory response. Increasing the steroid load is important. That kind of process of immunomodulation is really, really important in terms of improving the outcome for these patients.
Again, something that would probably benefit from some controlled trial data, because again, it's so difficult to really know which bit of the package is making the difference. But I guess that's the problem with critical care and what you do, is that there are so many different things that actually trying to sort out exactly which bit of the puzzle has been the key one is very difficult to disentangle. Nick, thank you very much.
Good. Thank you, Mark.
So what I'm going to do now is really just summarize where I think we are at this particular stage in the pandemic. It's pretty clear that while we know a lot more than we did at the beginning, there still remain many, many issues that are not entirely clear. A lot of what we do is still based on opinion rather than evidence. We've heard about two different approaches in London, tending to favour more the use of invasive ventilation, whereas Stefano in Italy favouring more the use of non-invasive ventilation. I think it's important to make the point that we really don't know which is the correct strategy here. I think it's very important when we start to compare results between different centres that we have to bear in mind that case mix, patient selection is very important in determining outcomes. And just to illustrate that, I've just put together two hypothetical cases, a tale of two cities. Centre A reports excellent results from CPAP, or it could be from proning, from non-invasive ventilation, nasal high flow or invasive ventilation, whereas Centre B describes very disappointing results from the same interventions. And then when we look at it a little more closely, we find that actually they have very different criteria for starting CPAP. Centre A starts it when the saturation drops below 94%, if patients receiving more than 5 litres of oxygen per minute with a respiratory rate of greater than 24 beats per minute, whereas Centre B is starting it when patient is more hypoxic on higher flow rates of oxygen with a higher respiratory rate, and furthermore is only doing it in patients who are not deemed suitable for endotracheal intubation. And it's very clear that one would expect Centre A to have much better results than Centre B, and we constantly need to bear this in mind. What do we know for sure? Well, this is a randomized controlled trial looking at the use of dexamethasone, and you'll all be familiar with this, that basically showed that you significantly improve survival when patients are given dexamethasone, but you don't see this in the generality of patients who are not receiving oxygen. And in our institution now, the start of oxygen therapy is a trigger for the concomitant start of dexamethasone. And I think that this has been a real game changer. And certainly when we've compared outcomes in the second wave compared to the first wave, there seems to be approximately halving of mortality, both in the general population in hospital, but also in the ICU. And while this may be due to a number of factors, dexamethasone is almost certainly an important component. When we first started these webinars back in March, there was a feeling that nasal high flow shouldn't be used primarily because of concerns about infection control issues, but also some concerns about how effective it really was. And I think that since then, there's been quite a lot of evidence that's come to light, looking at, first of all, the infection potential from nasal high flow, which suggests that it is similar to other forms of non-invasive ventilatory support, and indeed may actually be less risky than things that we wouldn't particularly have been bothered about at all, namely just standard oxygen therapy. And as this study shows, patients receiving oxygen through a Venturi mask, that you actually see greater dispersion of particles than you do with nasal high flow. I think it's very important just to realize that these sorts of studies are very dependent upon the size of the particles being measured. Perhaps the really important thing is what happens in the real world, and this is a recently published study from Thorax looking at seroprevalence amongst healthcare workers. And basically, it was the people who were at the highest risk were actually those who we wouldn't even have thought about at the beginning, namely those working in housekeeping. And those least at risk were those working in the intensive care unit. Now, this may be due to the way that PPE is used, it may be due to the ventilation within these different areas, but it may also be due to the fact that while we've been very concerned about the infection potential of nasal high flow or CPAP, that we failed to appreciate that perhaps the biggest risk is coming from the patient sitting on the ward who is not on oxygen or anything else, but is coughing. And while there are a lot of studies looking at the different sorts of effect on different particles and so on, the really key question is what happens in the real world. And a number of the studies that have reported data about the use of nasal high flow, none of these are randomized controlled trials. That what's very reassuring is actually the low level of positivity amongst the staff delivering these interventions. And it's quite possible that the people who were positive actually got it outside of their work environment, or at least outside of the intensive care unit. So I think that the feeling that nasal high flow and indeed CPAP was a major infection control risk, that concern has diminished, but that doesn't mean that we shouldn't still be very stringent in our use of PPE, about the ventilation of the rooms that we use things in as much as we can, etc., etc. Stefano talked about how their feeling about the use of non-invasive support had changed, greater use of nasal high flow, and indeed Nick also mentioned that that had become their modality of choice. This is not a controlled trial. This is a large case series from Italy looking at the use of nasal high flow CPAP or non-invasive ventilation. And what I've done here at the bottom is put comparable figures from the FRAT study looking at the use of nasal high flow in non-COVID hypoxemic respiratory failure. And what you can see is that, broadly speaking, if we compare 30-day mortality, the figures are broadly comparable. We don't have it for CPAP, obviously, but for nasal high flow and for non-invasive ventilation. Stefano talked about a hierarchy of nasal high flow, CPAP, non-invasive ventilation, and this again seems to be borne out from this study, where you can see that although the results were broadly comparable, the patients receiving nasal high flow had lower SOFA scores, had higher PaFiO2 ratios, and a lower respiratory rate, suggesting that this was a less severely ill cohort of patients. So I think now that when thinking about the non-invasive support, nasal high flow, CPAP, non-invasive ventilation would be the hierarchy. But of course, we don't really know which is the right approach. This is a study still carrying on in the UK, the Recovery RS, which is comparing various respiratory strategies in COVID-19, namely CPAP, high flow, and standard care. The target number of patients is 4,000, and to date, only 513 participants have been recruited. I think it's an extremely difficult study to recruit to, and sadly I suspect that they will never get to the 4,000 patients, but hopefully there might be enough patients to at least give us some messages, because clearly this is an area that desperately needs a randomized controlled trial so that we really know what is absolutely the right way, the best way of doing things. We've mentioned proning. Everybody's been very familiar with the concept of proning invasively ventilated patients in the ICU. But one of the things that came out early from Italy was the observation that patients who had predominantly posteriorly distributed inflammatory change on their CT responded very well to proning. And this is a simple meta-analysis of proning conscious patients on medical wards that basically really just confirms feasibility, and that you can see short-term improvements in oxygenation and respiratory rate. But as Nick Hart made the point, that these benefits are only apparent when the patient is in that position. It's not a treatment as such, because as soon as the patient moves, then you lose the benefit. But Stefano told us about the use of proning together with some form of non-invasive ventilatory support. And this seems a very reasonable way to go. Patients can't lie on their front for 24 hours a day, but by the same token, staying on a non-invasive interface and positive pressure or whatever, or nasal high flow for 24 hours a day is quite a big demand on a patient. And to be able to have two different approaches that both improve oxygenation, respiratory rate, etc., is clearly very appealing. But again, this is an area where we need more trial data, and in particular randomized controlled trial data. And I think there are one or two studies in progress with regard to that. Nick Hart made the point that we shouldn't forget what we've learned from other disorders. And this is a slide taken from one of the early presentations that we had from China, from Professor Zhang, who took us through the management of ARDS. And so I was particularly struck by his presentation of this study published earlier this year in the New England Journal, really showing that hypoxia is dangerous. This study was in ARDS, it wasn't in COVID, but showed that basically if you had a conservative oxygenation strategy, you had a higher mortality than when you targeted a higher oxygen level. And you can see the numbers there and the death from any cause at 28 days. And importantly, in the conservative oxygen group, they saw 5 mesenteric ischemic events. So we should not be complacent about hypoxemia and that we need to treat it aggressively. I think we do need to be careful about basing practice too much on theory. I think that the whole concept of patient-induced lung injury became quite prominent early on in this condition, and this was a review that was written in JAMA, basically was making the argument quite strongly of the importance of patient-induced lung injury. And it was followed by this review article from the group from Chicago, suggesting a rather more cautious approach, and that basically highlighting the fact that the evidence for patient-induced lung injury, in contrast to that for ventilator-induced lung injury, really is very, very limited indeed. It just makes the point that we need to be careful about driving care just on theoretical basis, because what this can lead to is inappropriately early intubation and prolonged ventilation, with patients staying on a ventilator for longer than they really need to because of a theoretical concern. So where are we now? This was actually a slide I produced earlier in the year, but I changed it very slightly, but most of the factors still remain the same. There is no proven right approach, that local factors are going to remain very important. Our intensive care capacity, the oxygen infrastructure, this is something that really came to light. It's not the problem of how much oxygen you've got on site, it's the size of the pipes that deliver it to the ward environments. And suddenly, as we were having to give large amounts of oxygen in wards that have never historically had to do that, it became an issue. The whole ventilation of buildings, the number of negative pressure rooms, the natural ventilation of existing facilities are important. We need to constantly keep reviewing what we're doing, and what's proved to be right for the first wave may not be right second time around and third time around. We need to learn from what has worked and what hasn't, and particularly on a local level. And the new normal needs to discover some of the old normal. Where possible, we need robust evidence-based practice, but accepting that that's not always going to be possible. But one of the problems that we've had in this pandemic is just the sheer volume of new information that has come out very, very rapidly. And the whole concept of releasing trial data or any sort of research data before it's been peer reviewed is something that we wouldn't really have considered before all of this. We do need to extrapolate from existing evidence, but we need to be careful in doing that. As I've said, we need to be wary of practice based exclusively on theory. And we need to learn the lessons here. I think it's very striking that the Asian countries have generally coped better with COVID-19. And I think that it's partly because they learned the lessons from SARS. And I know that some of those lessons have translated into differences in the way that hospitals are designed, the way that patients are managed, etc. And we absolutely need to extend what we've learned from COVID-19 into the management of other conditions. So with that, I will conclude, and I'd like once again to thank Philips Respironics for hosting these webinars. It's been extremely helpful, and we've had very positive feedback from a large number of clinicians, and particularly to Fang Cheng, who's been the main driving force behind it. So thank you very much to Philips, thank you very much to Fang, and thank you all for your contributions over the last few months.